can't see you. Well, give me a wave if you can hear me okay. Do excuse me. My colleagues phoned me to see if we can get this recorded, this session, so do excuse me. Hello, I want to record the vital signs. Is it where am I going to see if it's glowing? Thanks for that. Every wave, we're being recorded live. Cheers, honey. Bye. Don't mock me. Look, I work in A&E, not technical. Has it recorded for all the other sessions? Okay, did it record this morning? Just a word of warning about the recording. It picks up every little conversation. That's all I'm going to say. It's very interesting listening back. So, all those things you did at the weekend, I suggest you remain silent about them. That laugh. Don't want to know. Okay, so we're starting early. I'm not sure how it's going to mess up the timetabling. I'm fairly certain it will, but I will email them and just say that somehow it occurred that we had this session at 3. Okay, so from your side, it might just look a bit strange, but hopefully I can sort it out without any too much excitement. So, did anybody do the pre-reading? This is where you say, no, Liz, it didn't upload. Don't panic if you didn't. Don't panic if you didn't. The pre-reading's always optional, okay? Okay. We'll make a start, and if anybody pops in, just because I know this is early and you were told 1:15, that'll be okay. So, we're going to have a look at the scoring systems. We're going to have a look at the vital signs. We're going to discuss those vital signs. Okay. We're going to have a look at how we would escalate. And we're going to have a look at and talk about why it's important. Okay. So I've put some things up there as to why it's important. Why do you think it's important to look at somebody's vital signs? Yep. You can know somebody's ill just by looking at them. You don't need the monitor behind you, but we're obsessed with looking at those numbers. I've had people cardiac arrest on me and their numbers were normal. Okay? The numbers are as good as your skill, so don't be de-skilled by the machines, okay? They're there to aid us, but it's about knowing how to manually count. Who's been in my sessions been talking about heart rates? Counting for 15 seconds and then times in by 4. Please don't do that. Okay, you know me and my love of the NMC. For those of you who don't know it, okay, it's Annex B. I don't know it word for word yet. So, use evidence-based practice approaches to undertake. Take, record and interpret vital signs manually and via technology. Okay, it's really key, manually. A whole body systems assessment. So I asked earlier, you kind of had cardiovascular spoken at you, with you, respiratory at you, with you, around you. Okay. Musculoskeletal, we're having a debate about, not to pinpoint you at all, but, you know, all of it. Anything that makes a bone move, that's included. Okay. Measure and interpret blood glucose levels. You'd be amazed how many times they get forgotten. Neuro-obs, and what it doesn't say on there, and if you've had the nutrition and hydration session with me and my obsession with the acronym and abbreviation PU, then you'll know what I'm on about. So, vital signs. What's a blood pressure? Yep. Heart rate? Yep. Respiratory rate? Yep. Oh, I like this. I feel like a game show host. Higher? Lower? Coming in. Oh, is that for me? You shouldn't have. Always. When we talk about neurological status, what do you think that means? Might also go along with... Yeah. Yeah. Have you heard the term disability associated with neurological function? So something called the A2E, so those of you who may have been in A&E. Okay. So these are the vital signs. Urine output. How important is urine output for those who've been in my sessions? And no, my soapbox. Absolutely. Okay. Oh, I'm not sure why that's done that. Okay, let's have a bit of a discussion. Why do you think there's age differences between when it comes to vital signs? Yep. So child nurses out there, you've got all of those vital signs to learn off by heart, because I've been told by Karen, your programme director, do not rely on the pause and pews. Okay, do know those values. Adults, we're a bit easier. We tend to be across the board, and we have a news too, and we'll talk about that in a moment. Those from the the mental health branch and learning disability, it will depend on the age of your clients. Okay, you may not necessarily do vital signs, but it's important for you to know what they are and why you would do them. Put gender. Why do you think gender is important? Yep.
Different concentrations of water in the body between females and males.
Yep. Hormones? Yeah. Oh no, there's a controversial subject. Are you referring to childbirth versus the flu? Man flu? This is recorded, I'm going to get in trouble. So, fitness level. Why do you think I put fitness level? Welcome. You've not missed a lot. In what way?
You're especially fit in heart rate to be lower.
Give me an example. I love it when they do that. Everybody else freaks. It's like, oh, I'd love to see your heart rate right now. Absolutely. So what about the unfit people? Mine's going along at 140 right now. Absolutely. Stress, anxiety. Yeah, all those things can affect.
Public speaking.
Can you tell I hate public speaking? It's not my forte. Ethnicities. Now, I know it can be a bit of a controversial subject when we bring ethnicity in, but it can play differently, okay? There's some diseases, some conditions that may affect a person differently, okay? So do be mindful of that as well. Medications. Why would medications affect our vital signs? Right. Blood pressure tablets. What would that affect? Water tablets. What does that affect? And fantastic. Your antiarrhythmias. Liz, that's a really two big words. Yeah, yeah. So the tablets that can affect our heart rhythm. Okay, if we have an abnormal heart rhythm, we call them antiarrhythmias, and they can help to regulate that. Anything I've missed, do you think?
Pain relief.
Pardon?
Pain relief.
Pain relief.
Yeah. Well, that's on too much morphine.
Oh, what's too much though?
Well, it's different for everybody.
And that's why I said it, absolutely. So definitely. So what does morphine do?
It sedates somebody.
It can. It's a respiratory depressant. Absolutely. I won't go into the details of that because I can see you all falling asleep already, because I know it's the end of the day and you know what I'm like. Right, we'll keep it relatively simple. Okay. Why do we check them? I've put some ideas up there, but let's discuss it. Why would we check vital signs?
If something changes,
Tom,
like if they don't look right, they look a bit sweaty or...
they look all shades of wrong. Absolutely. Okay. I'm going to be naughty now. Ladies in the top corner, just because you made eye contact with me, fool. Person's blood pressure is normal, 120 over 80, and suddenly their blood pressure is 100 over 40 in the space of 10 minutes. Oh. Something's gone wrong, hasn't it? Absolutely. So we'll do it for a baseline. So those who may go and work in outpatients, if you don't already, I'm aware we've got a variety of different people in here. You might do baseline observations as part of pre-assessment, so pre-assessment for operations. So you do your pre-assessment and you go into theatre and suddenly somebody's got a really funky heartbeat and it's all of that sudden, let's go to A&E. And we get the phone call in A&E, yeah, their heart rate's wrong. Can you give me a bit more information? Okay, so we'll do it for baseline, we'll do it for deterioration, so the blood pressure. What else? We've mentioned medications.
Determine whether you can afford to give them more medication.
Oh, that's an interesting term, afford.
As in, if someone's blood pressure is high,
Yep.
we want to give them something to reduce their blood pressure. There's an oxygen saturation rate, or you might not be able to afford to give them.
Yeah. So we look at if we can titrate accordingly. So if we give one drug, is it actually going to affect their other systems? Absolutely. It's that homeostasis. Thank you. This is a long PowerPoint, but I promise to whip through quite quickly. Most of it will be you guys answering. Okay, so as I discussed earlier, News 2 for adults, Royal College of Physicians 2017. With PEWS, unfortunately at the moment there isn't a national PEWS or PAWS chart. Now PEWS stands for Paediatric Early Warning Scoring System. So those who are going to be our paediatric nurses, what do you know about it? What do you know about local trusts and PAWS and PEWS? Is anybody brave enough? So effectively they're age related. Okay, so as we know, children from fresh out the packaging to just before adult, okay, they're going to have different parameters. Okay, babies are going to have faster heart rate, faster respiratory rate because everything's brand spanking new and it hasn't yet kind of worn in. Okay, does that make sense? Their parameters are going to be much higher. Mental health and learning disability, again, it depends on the age of your client and the role in which you're working with them. Does that make sense to you folks? Yeah. For you, you might use other tools. So for mental health assessments, you might use a different kind of monitoring system that's more about visual cues and looking at the patient or the client service user. Equally, that may be the same with learning disability. But in terms of vital signs and observations, we tend to use these two. So, everybody recognise that? Now, you'll have to excuse me, those from the child branch. I couldn't find a decent PEWS form. But effectively, the difference is between, so this is a News 2. On your PEWS, you will have specific parameters. You will have glucose, because that is essential monitoring in children. You will have capillary refill time, because again, that is an essential monitoring in children. They are indicators of the child, status of the child hemodynamically. Any questions on that so far, or pews? I'm not a specialist in child, I just, from working in A&E, I have a sense of it, okay? Any questions so far? So there's no, it could be called pews or paws. In the local trust, I'm not sure what they're using, but effectively it's an early warning score, and it's to let the nurse know what's going on with the child. Okay, so the question was, is paws or pews the one that's used in practice? So what parameters are on there? Can you see that okay? Okay. The top it says Attenborough. That one is basically respiratory, so airway and breathing. Then you've got A and B 2. So effectively, you've got those who don't have COPD, and you have those who have got COPD. What's the difference from maybe what you learnt today about the respiratory centre and the respiratory organs about COPD? Yeah. Fantastic. So as part of the Royal College of Physicians 2017 update, they included, because we were over-oxygenating patients on patients with COPD, and that caused them to retain carbon dioxide, CO2. Okay. So if your patient comes in and they are known to have COPD, you must get the doctors to prescribe scale number 2. I haven't got my clicker thing today. So then we've got oxygen. So can you see the next third one down, oxygen? You've got those ranges, okay? White will always tell you that that is normal, okay? And I always do that as normal because what's normal? There's textbook normal and then there's the person normal. Okay, so white usually indicates normal values. And as you can see, did that come up? Yes. So we've got 12 to 20. Above 96, 88 to 92 on that second scale, and then we've got air for oxygen. Bless you. Multi-talented today. Blood pressure, can you all see me circling that there? Perfect. I normally like to stand there, but given you can't see, I'll stand here. So effectively, all these white bits are what we deem as normal values. However, it also suggests that 201 to 219 systolic is normal. What do you think? Absolutely, that's really high. Now, one of the interesting things that I find about the news too is we don't count the diastolic. We only count the systolic. So what you've learnt from the wonderful Joanne today, how important is the diastolic or diastole? You're all looking at me quite blank now. So we've got systolic, top, diastolic, bottom. Do we know that much? Fantastic. Okay, let's stay there and we'll work on it. So effectively, news 2, we only score the systolic.
She said we're only interested, I've asked her, she said we're only interested in the contraction of the heart, which is the...
It is. Diastolic comes in second year, but it becomes a little bit more. But yeah, so that's why it's not. Pulse. Is the pulse the same as heart rate? Very good. Do we tend to use both pulse and heart rate in the hospital? Or what's their heart rate? What's their pulse rate? Okay, you might find that in some areas they will use them interchangeably. Just be mindful. Okay. So we've got respiratory rates there. What are the heart rates? Do you know? That really is quite bad. Sorry, folks. Do you know what your normal ranges are? Okay, so you've got 60 to 100. Which textbook? Which textbook? Ross and Wilson. And the reason I say that is because the Royal College of Physicians say 90. So some textbooks, especially some of the American textbooks, might put you in the higher banding. So that's why I say it will depend on which textbooks. I was playing devil's advocate, sorry. Is that making sense so far? So we're painting a picture, aren't we, by the News 2 score. Neurological status or disability. Have you heard of ACVPU? Yeah. Okay, we'll go through that in a moment then. And E. Do we know what E stands for? Yeah, absolutely. At the bottom, it gets you to put your score on. Now, being anally retentive that I am, I also put urine output and blood sugars on there. Most wards won't do that, okay? In your ITUs and your EDs and your crit cares, we will have specific paperwork to add on. Is this making sense so far? Have I lost you? Kind of like that. Okay. Do stop me if I'm going too fast. Okay. So sort of why we would measure blood pressure. Okay. From your nutrition and hydration, what do we know about blood pressure and how nutrition and hydration can affect it? Yep. Yep. And the other person? Yeah. Yeah. Just before lunch, who was feeling a bit dizzy because they'd been sat in here all day? Or all morning, rather. Yeah? There's probably lots of reasons why, but you might have been a bit dehydrated. I've now learnt to bring water with me because I definitely get dehydrated. Okay. We've talked about blood pressure tablets and antiarrhythmias. When we're doing blood pressure, why else? We'd check, wouldn't we? So patients hypertensive, we give them an antihypertensive, and then we read their blood pressure in about half an hour. Why? Yeah. Has it worked? The effect of the medication? Because it might be it's the wrong medication. So can you see how actually by us monitoring people's observations, we can see what we've done to them in terms of giving medication, but also anything that's happening as part of their condition. Does that make sense so far? Thank you. Because you know me, I'll ask questions, more questions if you don't answer me. I need to know that you're sort of with me. Okay. So I said, what is meant by it? And we've said it's the force. Okay. Mean arterial pressure isn't monitored on the News 2 chart. The reason I've brought it up because actually the Dynamaps, who's used the Dynamaps? Yeah? So it's the electronic machines and it'll give you a top number, systolic, give you a bottom number, diastolic, diastole, however you pronounce it, whichever way. It'll also give you what's called MAP, and that is mean arterial pressure. Okay? If your patient starts to lose their mean arterial pressure, then actually systemically, they're going to be really quite poorly. Okay, organ perfusion requires a certain amount of mean arterial pressure. Now, as first years, when you go out in the wards and start talking about that, they're all going to go, why do you know that? You're a first year. But it's important to know it, okay? It becomes really important in the crit care next year for both children and adults, but just know about it, okay? Do you know about cardiac output? Do you know about stroke volume? Do you know about systemic vascular resistance? No. Okay. I'm not going to scare you. There is a video that I can get uploaded, okay, and we'll pop that on for you. Any other questions on that? Can you understand how actually a blood pressure is really complex? It's not just whacking on a machine, putting on a cuff, pressing go, walking away and coming back 5 seconds later.
How would you get the mean arterial pressure if you're doing blood pressure?
It takes a bit of complicated calculations, if I'm honest. and I don't always get it right. Okay, so it is complicated, which is why we introduce it. That's why you need to know about systemic vascular resistance, cardiac output, and stroke volume. Okay, as a first year, I don't expect you to know how to calculate, just know what they are and why they play an important part. In ITU, we tend to use the mean arterial pressures via arterial monitoring, because that gives us the most real-time, up-to-date blood pressure. Because your Dynamap might tell you you've got a blood pressure of about 100, realistically, you've got blood pressure of about 60, with a mean arterial pressure of about 20. That means that your organs are starting to fail. Okay, I'll stop there, because you know me, I can carry on. Okay. Abnormal ranges. Why is it important to know your abnormal ranges? People die. People die if we don't recognise it. Yeah. You let it hover along, worst case scenario, people die. Okay? Know your abnormal ranges. Know how to escalate them. In children, blood pressure, when I do them in A&E, we tend to not do them routinely, but unfortunately, a low blood pressure in a child is a late sign, and they're going to arrest. Okay? At their 95th percentile growth, if you don't know those numbers, the risk is you're not going to know if that's a normal low blood pressure or not. They might come in with congenital heart disease. Okay? You need to know what your treatment is for blood pressure in children for the child nurses. Mental health and learning disability, because you have a combination of clients vast all the age groups, okay, you need to know what your tools are available out there, depending on where you are, and what age group you're looking at. By the way, to those child and the smaller fields, is this feeling a bit more inclusive? Do you feel like you're actually being taught some of your relevant content? Okay, fantastic. Hypertension and hypotension. Hypertension in children. I don't know the statistics, as I say, I'm not a paediatric nurse, so I'd have a look into it, okay? But hypotension, again, could be normal for that child depending on what is going on and what age group they are. In adults, hypotension can be as a result of anything. They might be ultra fit and their blood pressure is 80 over 40. They might have acute kidney disease, they might have chronic kidney disease, they might be on dialysis. They may be low riders at 70 systolic. That is normal for them. It scores a 3 on the News 2 chart. So can you see why I talk about normal values? Is this making a little bit of sense? Just some small nods. Okay. Pulse, heart rate. Okay. Did anybody do the pre-reading around this? Anybody know get any more information on this? No. Thank you for your honesty. Okay. It's the heart rate. Your pulse is what we feel peripherally or centrally. So do you know what that peripheral and central is? Yeah. Yeah. So either on our wrists or in our neck. We tend to not go femoral because you can imagine how that might see. Okay. I don't want to go onto this too much because I'm hoping it's been covered in the cardiovascular and I don't want to overwhelm you after a long day. But effectively, when you're on a cardiac monitor, the Pluth, or the wave, is going to give you that number. Okay. Bradycardia. Okay. I've put it can suggest low output, but actually it could be that it's normal for our ultramarathon runners. Okay. Tachycardia, fast heart rate. Who's ever walked up AMB stairs? Suddenly your heart's going to give out. Aerobically, you've put your heart under a little bit of strain. Just a little bit of strain. I've walked up there, so I know the strain my heart goes under. Equally, when our marathon runners, even if they are ultra fit, when they are putting themselves through those 100 milers, those 200 milers, actually, they're putting their cardiac system under a lot of stress. Okay? Is this making sense so far? Sepsis. We talked about sepsis, didn't we, very briefly? Does anybody know how sepsis affects the heart rate? So we'd use the term tachycardia, okay? Now that's because the complex pathophysiological process that's going on, okay? So it's not always exercise-induced, it's very often it's disease-induced, okay? Why would I be worried about a tachycardia if the person hasn't gone up the stairs and they're just sat at rest? Because it's not normal, is it really? They could have arrhythmias. What about bradycardia? Are we worried about bradycardia? Yeah. Why are we worried about bradycardia?
If it's abnormal for them, yeah.
So if they're not known to be, it could be they're an overdose. Absolutely. So there could be lots of reasons why our patients are bradycardic. It could be they're peri-arrest. Okay, so know your terms and know what can cause them. Pulse rhythms. Did Joanne go through a couple of rhythms with you? Do you know the term sinus? Yes, the sinus is our normal rhythm. Okay. We've got tachycardia, as I said, we've got bradycardia. We have atrial fibrillation, atrial flutter. We have supraventricular tachycardia. We've got ventricular tachycardia. This is all recorded, so don't worry if you can't keep up. Okay. We've got asystole. We've got pulseless electrical activity. Okay. We've got other arrhythmias. As a first year, what I'd like you to know is your sinus rhythm. Okay. Your normal lub-dub, as we call it. Just know your normal sinus rhythmia. Okay. Because anything that isn't sinus is going to look wrong. So what are you going to do? If it looks wrong, it might be wrong. It might be somebody's done a dodgy job on the ECG. Yeah. So if it looks wrong, do something about it. Okay. You don't need to necessarily do an ECG either. You can feel irregular pulses. Okay. So put your pens down, put your phones down, and feel your wrist. So I'll try to get you doing something. And if anybody says I haven't got a pulse, Casper. The reason I've got you all to feel your wrists is you are looking at your radial, you're feeling your radial pulse. We have some patients whose radial pulses go on the other side of their wrist. They're the ones that really get you. You have to kind of work around, suddenly you find it and it's in the wrong place. Okay? So ideally, the radial pulse is around here, but it might not be. So if you've all got a pulse, the person who's coughing, but you're going a bit faster than normal. Does this make sense? If you've got an irregular pulse, please don't tell me. So not only do we need to know about, I'm aware of the time, what our pulse is doing, we need to know, is it strong? Is it weak? Is it bounding? Is it thready? What do you think a thready pulse is likely to mean? It means somebody's really not well. Absolutely. So we've talked about tachycardia. What about bounding? When do you think you'd have a bounding pulse? When you walk up the A and B stairs. So that would be exercise-induced. But you might get some babies who've got a galloping rhythm, and that's indicative of a certain cardiac issue. Okay.
You get that with like an adrenal problem as well.
You can do, yeah. So if somebody has an adrenal crisis, they can have acute tachycardias along with everything else. Absolutely, yeah. One of my favourite arrhythmias is Bigemini and Trigemini, just because they look so cool. They're really not. But on the monitors, they actually look very cool. They're actually very serious. So, we've looked at radial pulse, okay. These are some of the areas we tend to not do axillary, and we certainly don't do subclavian. But we do brachial. So in children, we tend to do brachial, okay? So, your brachial, people call it the crease of your elbow. It's the antecubital fossa, okay? And your brachial artery will be around there. So those who want to have a go at feeling their brachial artery, have a go. And that's why I've got you to have a go at finding it, because actually I find that to be a bit tricky. Not least in an emergency where your own heart's going like the clappers. Okay? Another place that we teach you in BLS, or Tracy Morris might have taught you, I don't think I've taught BLS to any of you yet, is the carotid. Yeah? Okay. What I would say is only go for the carotid if you are trained. We record it under the pulse section of the News 2 chart. On the pause, pews, or whatever else it goes for in clinical practice, you would put it under the pulse section of that. Doesn't tell me what the rhythm is, though. So if I've got somebody who's got an arrhythmia, and 1 minute's 60, and the next minute's 85, which one am I writing down? Being the savvy person I am, in the patient's notes, I would say actually it ranged between 60 and 85, arrhythmia. On there, I would probably put the higher, 85. Ever in doubt, escalate to your practice assessors. Does that make sense? Okay, it's why it's important to know those arrhythmias. So, for the paediatric nurses, okay. For you, you have a traffic light system. Your traffic light system will tell you the escalations, okay. Now this is from Royal Blackburn. I only gave it as an example. You'll need to know what your local trust policies is, but effectively it's a traffic light system. And you will have scores of red, orange and yellow, okay. What do you think is going to be the most important? If your child of 3 is pewsing at 4, not too bad. If your child of 3 is pewsing at 10, get them into resus, because they're likely to have a collapsed lung and they might have something else going on, okay? And they are the children who refuse to have oxygen on and will scream and scream and scream and scream and scream and scream and scream, and no wonder they go in tachycardic of about 210, okay? You always escalate to the senior. And if they don't listen to you, scream. Screaming works beautifully. Okay. And usually the lines of, I've got a really sick kid here, gets everybody panicking. So know your scores and know your escalations. Okay. For those in the adult, or those who would be looking after adult, in your News 2 you will have, or rather on Nerve Centre, it will tell you, please seek senior advice. It tells you what to do. But for those of you who are going to work in an area where it's still paper-based, then actually the back of the paper will tell you the escalation process. Is this making sense so far? Don't sit on... I'm not going to continue that sentence. If your patient is poorly, please don't not escalate it. So escalation. Okay. So again, I've put that children's heart rates can range, and they do range. So for you in paediatrics, if your child's heart rate's hovering between 59 and 60, it's likely you're going to be asked to do CPR, okay, because those ranges are not the best for sustaining that baby's life or that child's life. Anything outside of the normal, even if your numbers are okay, but your patient looks all shades of wrong, if there is something in your gut saying this person, this child, is not okay, then tell somebody and write it in the notes who you've told. Okay. In terms of numbers, the higher the news score, it's like a pointing system. Higher points is not a prize. Higher points means you get the consultant and you get those senior members of staff in there and help them. Capillary refill time. Okay. Not routinely done via the news chart, but actually it's a really good indicator of cardiovascular health. Okay. We're looking at about 2 seconds. And as I said, in pews on the children's, CRT is an indicator, and you do it centrally. I'm not sure why we don't do central capillary refill time on adults. I mean, capillaries are kind of here, but we tend to do central refill times on children's. We can do it on adults, but we tend to just stick with capillary. Do you know how to measure a capillary refill time? Squish the nail bed for about 5 seconds and then see how quickly it goes pink. Marvellous. So you do it, and your adult patient, it says it's 6. And you're there going 1, 2, 3, and the beads of sweat. 4, 5, 6. I'd have shouted at 4. Yeah. As I say, it is done, but it's not documented. So again, it's worth having a talk with your assessor and saying, can I practice the skill of capillary refill time? And I think there's more important things you can do, but it's a good indicator of cardiovascular. Okay. So, you had a GETHA just before, so you know all about respiratory. I'm not going to go over too much, but effectively, respiratory is our breathing. We've got our lungs. We've got our alveoli. We have the bronchus, the bronchioles. Where else? Where else do we, is our respiratory? Do we talk about the brain? Respiratory centres in the brain? Okay, so in our brain we have some respiratory centres, and they will respond to changes in oxygen and carbon dioxide. Okay, so again, it's about having a look at that as well. So we have pulmonary ventilation. Have I lost you all now? Yeah. Is this new?
It was all a bit fine now.
Okay. 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 We breathe in, we breathe out. Okay, let's make this really basic. You breathe in, breathe out. Okay, what we want is a good homeostasis and balance of oxygen and carbon dioxide in our blood. Okay, we have a term called gaseous exchange, and that's where our CO2 and our oxygen and hydrogen ions, they will transport, osmosis and diffusion. You all know those words? Okay, through a semi-permeable membrane. Okay, so effectively that's what our lungs want to do. The respiratory centres in our brain will respond to whether we are hyperventilating, hypoventilating, depending on what gas is going on in our body. Okay, is that making sense so far in a really simplistic way? Perfect. So as I said, we've got ventilation. Okay, so we breathe out, we breathe in. We expire, we inspire. Respirate. What's that stand for? Respirations. Because in the trust we just go, what's their resps? Who likes abbreviations? Who hates abbreviations? Okay, resps to me says you've had some crisps in your mouth and you've got a bit of a lisp going on. No offence to those who have got, by the way, I do occasionally have one when I'm dry. But it's really important to know what people are saying if we're taking care of other people. So, we've got transportation of gases, and we've got internal respiration. Okay, those are some key things to have a look at. I haven't put it on here. I have Doherty and Lister, so that's the Royal Marsden. The Royal Marsden 2015 is freely available in the library, but also the 2020 edition is available. Have a look at the chapter. It goes really nicely into gaseous exchange. It talks about the oxyhemoglobin curve. Don't worry about that in level 1. Okay, just know about gaseous exchange and the function of your respiratory system. Okay. Does that make a bit more sense to kind of what you understood from Ajitha? Sort of. You'll get there. You will get there. It's the first indicator of somebody deteriorating. It's also the least appropriately and correctly, I am on my soapbox now, monitored vital sign. People will count 1, 2, 3 to 15 and then times by 4. I might have stopped breathing for 3 seconds. Am I going to get an accurate number? In children, they could be respiring away at about 40, 50. Trying to watch them breathe is really interesting because you really are going with them. But it's the key is watching them breathe, okay? Because actually how children breathe indicates the distress that they might be in if they're over and above their normal numbers. Bit of oxygen, okay? So, as I've highlighted, we need oxygen, okay? How much oxygen's in the atmosphere? 21. Go on. Yeah, about 21. So, you know, on the News 2 chart and the Pews chart, when it talks about oxygen, and it talks about those levels, interestingly, in BLS, when we did give mouth to mouth, as in my mouth to another mouth, how much oxygen did I give, or would I give? Have a read on the textbooks, because it talks between 16 and 20, okay? So it's not as much as it should be, but it can be life-sustaining. It's a bit of oxygen. So digress. Oxygen binds to hemoglobin. So our patients who are anemic are going to have less oxygen in their body, aren't they? Potentially. Anybody disagree? Whose phone or tink was that? Oxygen and hemoglobin. Didn't cover this in respiratory? Okay. Basically, if we've got 75% of oxygen bound, then our SpO2, so that's the finger probe that gives us that blue pluth, okay, will give us about 75% oxygen saturations. Is that an okay level of oxygen? No. That's all you need to know, okay? Just remember what the normal ranges are, and anything out of that is abnormal. As for what you're going to need to know for the exam, I don't know, but a good start would be gaseous exchange, knowing about how oxygen transports around the body, and knowing how oxygen binds, okay? As I said, I'm not writing the exam, I don't know what's in there, but that's a good start. This will be put up, so don't panic, okay? And it's being recorded. So pulse oximetry, as I say, finger pluth, although I've just realised that's sort of a bit of a rude picture if you look at it in a quick glance. See, now you're all looking at it. So, if we don't have this available, but our patient has got a blue tinge, our Caucasian patient has got a blue tinge, are we worried? I'm so glad you all said yes. Okay. Our patients who are not Caucasian, and they may be from a BAME background, they might present slightly different. They may be pale. Okay? Are we concerned about that? We need to be. You need to know your differences of how different patients from different ethnic backgrounds will present with cyanosis. It is something that's missed, and it's something I'm really passionate about. Okay? And there's quite a good bit of evidence around it. So we've said that 96% is a good range. 88 to 92 is a good range for... Okay, your patient comes in, they have got COPD, but they're sat to 94% on air. Well done. Yeah, that's fine. We're not worried. Patient comes in and their SATs are 86%, they've got COPD, we put them on 4 litres and suddenly their oxygen shots up to 94. They then become confused. Worry. Who said that? Fantastic. Why? Fantastic. Absolutely. Yeah, absolutely. We can actually over-oxygenate non-retaining people. Okay? We have to be really cautious with oxygen. That's why it's prescribed. As a nurse, can you give oxygen in an emergency? Yes, you can. I never hesitate to give oxygen and then get it prescribed, because in a court of law I will stand there and say why I did. Hypoxia will kill quicker than hypercarbia, high dioxide levels. Okay, I will not hesitate to give oxygen to a patient who needs it, but that's because I've got the skill set and I've got that knowledge base. So can you see why you need to know about oxygen levels? Is this making sense? Fantastic. So your patient comes in, so in A&E, homeless person over Christmas, and they come in, they've got a temperature of 32 degrees and their hands are freezing. Are you going to get a pulse ox? No, absolutely not. How are you going to get the pulse oximetry? So they're blue. They've been lay on the ground for 4 hours and they've had a cardboard box over them. Do you know what? Yeah. If they're confused, actually what I might do is look at some oxygen, speak with my colleagues, warm them up. Okay? So there will be situations where our patients are of a blue tinge, but it might be because actually they're suffering from hypothermia, okay, which also causes us to not be able to get oxygen levels. At that point, I'd probably do an arterial stab and get SaO2, which is arterial saturations. This is different ways. For children, cyanosis, again, is a late sign. Okay? If your babies are blue with 15 litres, it might be a congenital heart disease. It might actually be that they're really sick. Okay? Common issues for respiratory disorders. Respiratory issues. Smoking. Pneumonia. Asthmatic. You've already said one. COPD. COVID? Yeah. Mind you, COVID's just chaos for everything, so, you know. Yeah. Pneumonia, chest infections. Because we have chest infections that don't lead to pneumonia, they're just a simple LERTI or ERTI. That's lower respiratory or upper respiratory. Pulmonary edema, fluid in the lungs, that pink stuff that can froth up. You've said it all. Respiratory failure, okay, can occur as a result of some diseases of the brain. Okay, so that's why it's important to also know what your respiratory centres are in the brain. Yes, sir. Yeah. Why pulmonary embolism? Because there's a clot in the lung. Absolutely. So again, I like Delves Yates. There is a new book, 2022, that is available as well. So, the first part of your news or your pews is your A and B. So it's your breathing, your respiration, and your oxygen. This is where you're going to focus your respiration and your oxygen on, okay? We've talked about the colour of the patient, cyanosis, okay? Depending on who the person is in front of us, they may present differently. When we're actually looking at our respiratory rate, what are we looking at? How fast they're breathing? How deep? So are they expanding their lungs? Have they got accessory muscles going? Are they doing that? Yeah. Are they seesawing? Is their belly and diaphragm going rather than their chest? Okay. Have they got musculoskeletal issues? That means that actually they can't breathe properly because of the way they're positioned. Noises. Absolutely noises. What kind of noises? Yep. Yep. Yeah. Chain stoking? Yeah. Agonal breathing? Okay. They're all different kinds of breathing. Agonal breathing and chain stoking, obviously, we worry about. What else?
Changing the breathing. Like if you've been watching them and they're breathing and then you look, it's different to last time you see.
Yeah, absolutely. And can you see why people miss it? When we're doing our patient's respiratory rate, do we do it discreetly? Because otherwise they go, is that normal? Yeah, it's going like the clockers now. Absolutely not. Don't let them know what you're doing because they will change their behaviour. Okay. Have you heard the term auscultation? Chest auscultation. Listening to the lungs for those deeper sounds. Okay. You learn about that in year 2, but again, it's another way that we can do respiratory. We can listen, we can find out what's going on. But respiratory rate is all about visual. For our child's nurses, we've got nasal flaring. Now, we do get in adult, but in children, it's pretty obvious that they're struggling. Tracheal tug. So you've got your trachea, and what can happen is it can suck in children. We call it a tracheal tug. In our patients who've not got a lot of subcutaneous or adipose tissue on them, fat tissue, we can actually see intercostal recession. Okay, and basically what the body's doing is it trying to suck in air, trying to get that oxygen in because they're struggling. Does that make sense for you guys, the paediatric nurses, wherever you are? Any questions so far? There was a hand.
Can I just see how it works?
You can. Yep.
And that's what continually checked all the time. Is that what we should check? Is that when you've got
So if you're an asthmatic, peak flow is what we use because it's about that peak expiratory volume. So basically what you blow out, you have to be at a certain percentage before we know that your lungs can actually cope. Okay, so in acute illnesses, your volume decreases, which is why when you have that peak flow, they'll say, oh, it's only 100. Whereas you might be blowing 400, so you'd be a quarter. Does that make sense? Perfect. So, different ways of delivery of oxygen. So we've got nasal cannula, goes up the nose. We've got face masks. We have non-rebreathes. For our patients who've got tracheostomies, commonly known as neck breathers, we've got tracheostomy masks. We have humidified oxygen because what do you think oxygen does to the nasal mucosa? It dries it out, you get nosebleeds, it's horrible. There was an and it's gone. Right, I'll leave you to your next question. So we also have something called Venturia, kind of like little add-ons that go onto the masks, okay? And they can limit how much oxygen that a patient has, okay? So we've got a whole tool of tricks that we have available to us, okay? Know them, learn them, and be prepared to discuss with your assessors. So breathing rates, 12 to 18, again with children. It depends on the age of the child. And as I say from Karen, you've been advised to learn what those are. As I say, it's the most miscalculated vital sign. So oxygen, so British Thoracic Society, BTS, so they suggest those, whereas actually the Royal College of Physicians suggest above 96. So again, there are differences. So some terminology, as I said, don't worry, this will be put up. You've got bradypnea, tachypnea, apnea. You've got dyspnea, hyperventilation. We talked about hyper and hypo. Hyper means high, hypo means low. So hyperventilation is when you've gone up A and B steps and all you're doing is just making your blood alkalinic rather than acidotic. Hypoventilation. So the lovely lady you said about opioids, respiratory depress, brings your breathing down. Hypoxia, low levels of oxygen. Okay, and SpO2 is peripheral saturations. Okay, does that make sense? It will make sense. Did anybody do that reading? Okay. So, neurological status or disability. Okay. The reason we check is because if a patient was alert and then suddenly they're no longer alert, we want to know why. Because it might be that it's part of their condition that we didn't know. It could be that they have been off for a cigarette and taken something illegal. It could be that being on the ward that they've taken something legal or illegal. It could be we've overdosed them. That does happen. We've given them too much morphine, commonly in our elderly population. I remember a patient being given 5 milligrams of morphine. They were prescribed 1 to 5 milligrams. They were given the full whack of 5 milligrams, and their respiratory went down to 5. So, how could you imagine they were? Conscious? So again, it's knowing why our patients could be unconscious, okay? I've said here we've got 3 basic principles, okay? I've tried to make this a bit more simple, just because you've had a lot of anatomy and physiology today, so I know, okay, you're a bit overloaded. But we've got sensory, so probably all a bit hot and cold today. We've got integrative, so our processing. Yeah, is this making sense? Does anybody know about neurological system? Have you done neurological system yet? Okay, so this will make sense when you have that session. And of course, we've got our motor responses. On the News 2 chart, we look at D, which is called consciousness, and that's where our ACVPU comes in. Okay. So effectively, it's the wakefulness of our patient, alertness. Our patients who have dementia, documented dementia, but can answer all the questions. Where are they on the ACVPU? Are they confused? Are they alert? I love being devil's advocate. So, yeah, absolutely. Turn it off quick. These things happen, don't worry. So the neurological status of our patients. So again, it might be we've given them too much morphine. It might be they've come into A&E and they're on a really good high, and I give them some Narcan and they really hate me because I've just taken that away from them. There might be they're in a diabetic coma. So can you see why actually with disability or neurological status we combine the glucose? Because actually low levels of glucose can cause patients to have coma, especially in our diabetics. Does that make sense? Yes? No? Okay. So, alert. And that's why I was saying about the patient with dementia. Known dementia comes into your ward. They're coming in not dementia related. They've got community-acquired pneumonia. And they're talking their normal, I don't know, best word to say, their normal sense of the world, but they're confused. Are they alert? Yeah. New confusion is just that. It's new confusion. Now, you might find on the ward, if this patient's new to the ward, they might put as a new confusion. But as a registered nurse in A&E, I will put confused, but not new confusion. So can you see how I'm justifying what I'm putting on that News 2 chart? Does that make sense? So new confusion is just that, it's new confusion. If your patient's got new confusion, neurologically something's going on. So we want to be worried. Response to voice. I think you're all currently responding to my voice. Yeah? So it is, it responds to voice. When might somebody just respond to a voice? When they can't hear you. So a patient who's blind. Are they alert? Or they respond to voice? Can you see how this can be misinterpreted? Because actually they're alert. The reason they've responded to voice is because we've been quiet and not announced our presence. Okay? Only responds to pain or stimulated pain. Does anybody know what stimulated pain is?
Not vigorously shown.
Hello? Hello? So I'm seeing lots of this. Okay, what we do is squeeze the trapeze. Okay, it's called painful stimuli. There's only two, really, that we can do. Does anybody see this out in practice anymore? Okay. My pressure might be different to your pressure. Because of that, the patient gets burns on their chest from me and you both doing a sternal rub. Patient still doesn't wake up. However, if I do that on their shoulder, that really hurts. Okay? The other one, you're all a blur now, is suprapubital orbit. And you really do push hard. If somebody doesn't respond to that, they've got a good going issue. Okay? They're going to be your unresponsive patients. Okay? We shouldn't be really pinching ears. We shouldn't be doing nail beds, really. What we should be doing is those authorised. You will see in ITU, they still do that, the anaesthetists. Advise them they shouldn't. But they'll probably tell you they've been doing it for years and they'll carry on doing it. And as I've said, person who's not conscious will score a 3. Do we escalate? Yes. Okay. So blood glucose monitoring. Okay. We've got some normal rates. In our diabetic patients, why do we monitor it? Hypos, hypers. Yeah. In our patients who are diabetic and they're on insulin, DKA, diabetic ketoacidosis. Yeah. Yeah. Kids are notorious for dropping their blood sugars middle of the night. So they're the ones, if they're newly diabetic, obviously their parents get told the regime and their parents don't get a lot of sleep. Okay. And that's why we put it in with altered level of consciousness, because has anybody ever been on shift and they've not eaten all day and it gets to about 5 o'clock, you're due to finish at 7, you get a banging headache and you start to just talk like you're drunk. I do that anyway, but anyway. But absolutely, so that's why. All children, as I say, as part of their pews, should have scoring. Your child comes in and it's a 2 millimole. Are you worried? Paediatric nurses? But they're screaming. What if they're not screaming? Then it's like, oh, damn. Oh, absolutely. The adult who decided to self-administer their insulin and didn't tell you, because they're all about their insulin. And suddenly, an hour ago they were talking and now they're flat. Are we worried? What's the first thing we're going to do? Check blood sugars. Test. Why don't we call them BMs anymore? Blood monitoring can also mean bowel movement. Can you see why I don't like abbreviations? BM is 3.2. Could mean a bowel movement of 3.2. Okay, so blood glucose. Okay. Any patient that presents as a loss of consciousness for no apparent reason, escalate. Okay, shout, pull that buzzer, whatever you've got to do to get that attention. So temperature, okay, can be affected by lots of different things. So in the summer we can get a little bit hot. I won't say the word because you all go, ee. So we all perspire a little bit. We all lose our heat. Some of us have got high metabolisms than others. Some of us have got slow metabolisms. Some of us are currently wrapped up to the hilt. Some of us have got T-shirt and shorts on. You know, we all have our heat differently. Medications can make us warm, they can make us cold. Circadian rhythms, time of the day, night sweats. Okay, some conditions like TB can cause night sweats, COVID, fever, all of those things. Are you with me so far? Okay. I'm aware of the time, so sorry folks, we'll whip through. So you've got tympanic, you've got oral, you've got axillary, you have temporal, and you have rectal. Patients who come in as a trauma or a hypothermic, rectal is the best way to get a temperature. Okay, it will give you the most accurate temperature. It isn't routinely used on the wards, as you can imagine, so only use it if you're able to. So normal values, 36 to 37. Our children tend to be a little bit warmer. So again, what's the issue with our children who come in with fevers? Our paediatric nurses or anybody really. Children who've got a fever. They can't. But what's the issue? What can happen with children who come in with... Yeah. How do you think a parent reacts to a febrile convulsion? Absolute panic. So actually temperature control, particularly in children, is really essential. What was that, sorry? Somebody said something about children. Yeah. They are scary. They are scary, definitely. And it's about just controlling it. Any questions on that? So, do you know the associated terminology? Hypothermia, hyperthermia, pyrexia, apyrexia. Febrile. Okay. So, if your temperature's normal, which one's it going to be? Apyrexia. Temperature's 40.2. Temperature's 30.6. Yeah, hypo, absolutely. In sepsis, we tend to say they're pyrexic. Okay. When we talk about hyperexia, they have to be over a threshold. So the common term is pyrexia or apyrexial. We're almost at the end. Well done. So, do you understand vital signs and why they're important? I know it's been a hefty session. You've done fantastic. Do you know why we have to escalate? Would you feel confident to escalate a poorly child or adult? Yes. Fantastic. That's all I need to know. Thank you very much, everybody.